And we'd like to, if there are health committee members out there, please come. This is the last bill we're going to hear today, plus a consent calendar. So if we can get some people down here, we are short of a quorum. We'd love to be able to vote on these bills and move on to our next item. So, Senator Pavley, whenever you're ready. Thank you.
Yes, thank you very much, Chairman Woods. First of all, I'm delighted to have 3 co-sponsors for this measure: Planned Parenthood Affiliates of California, the California Family Health Council, and Narrow Pro-Choice America. SB 999 is an important bill to provide greater access to birth control and reduce the rates of unintended pregnancy in California, simply changing the timing of contraception dispensing. Right now, most people are limited to 30 to 90 days. This bill would simply allow a doctor an option to increase it up to 1 year, but require it as part of managed care insurance plans. That's what it is. The doctors still have the discretion in the dispensary at a pharmacist. They have discretion to limit it as needed to 30 to 90 days, but up to 12 months makes sense to me. People are busy. We know if you're taking birth control medication, you need to make sure you take that every day. Gaps in taking contraception can cause unwanted pregnancies, and heaven forbid, people making a difficult choice for an abortion. You've had health review organizations look at this and see the fiscal impacts and the savings of providing contraception over a longer period of time. If you live in a rural community or you're a busy person between jobs and things, you cannot always get every 30 days a renewal of your prescription. This just makes sense. And California is not leading the way on this. Oregon already has adopted this program, no waiting lists, etc. They've moved on. Other states have introduced this. These bills are moving forward across the nation. It's consistent with family pack planning and the recent Medi-Cal managed care decision that came out in February of this year. So what this bill does is requires health insurers and healthcare service plans to cover up to 12 months of FDA-approved self-administered hormonal contraceptives at one time. I want to emphasize again the up to discretion of the doctor or the pharmacist, right? So people concerned about whatever reasons they have, the new patient or whatever their concerns are, they have that professional ability to limit it at the beginning, go up to 12 months when and if they think that's appropriate. Senate Bill 999 now has a long list of support. Told you in June, last year, Oregon enacted it. There's no problems there, no known problems of waste or any of these other kinds of things that brought up in concerns. Several other states have introduced bills, and in recognition of the benefits of 12-month supplies, both the Centers for Disease Control, the CDC, and the American Congress of Obstetricians and Gynecologists now recommend annual dispensing. Our own California Health Benefits Review program found that fewer unintended pregnancies and office visits resulting from annual dispensing will save industry, government, and consumers approximately $42 million a year. Your analysis clearly went through all the benefits on the fiscal side of this. And so with that, I'd like to introduce a few witnesses I have today. I understand it's 2 minutes each. Is that correct?
2 witnesses, 3 minutes each.
2 witnesses. Okay, well, they mean...
But if you got 3 and you want 6 minutes, I'll grant you that.
No, I think I have 2, and they'll be about 2 minutes or so each.
Perfect.
Is that fine?
That's awesome.
And then we have some other people introducing to you. Amy Moit from California Family Health Council, Dr. Mitchell Crianan, Professor and Chief of Family Planning in the Department of Obstetrics and Gynecology at UC Davis, and here also on the dais is Deborah Rottenberg, Legal Counsel to Planned Parenthood, here for any technical questions.
Wonderful.
All right.
Thank you.
Amy?
Thank you.
Thank you, Senator. Good afternoon.
Yeah.
Good afternoon, Mr. Chairman and members of the committee. My name is Amy Moy, and I am Vice President of Public Affairs at California Family Health Council. CFHC is a proud co-sponsor of this bill. We administer the federal Title X Family Planning Program, and through that program, we support the delivery of quality family planning services for over 1 million women, men, and teens throughout the state. Women across California with both public and private health care coverage need and deserve equal and consistent access to their prescribed birth control method of choice. As the Senator noted, the research is very clear. Providing an annual supply of contraception is a significant contributor to helping reduce unintended pregnancies and saving dollars along the way. While SB 999 is a legislative innovation, California, if passed, would be the second state in the country to pass a measure like this. Providing a supply of birth control for a 12-month supply of birth control is not new here in California. As the Senator mentioned, this has long been a standard of care utilized under our Family PAC program, and recently women enrolled in Medi-Cal managed care plans can access a year's supply of oral contraceptives at once. SB 999 trusts women to be able to follow instructions given by their health care providers and store their medicine appropriately. As leaders in California have long understood, increasing access to birth control is good for women, families, and the health of our state. This bill continues our state's leadership and long history of commitment to breaking down barriers to reproductive health access and advancing policy solutions that help reduce unintended pregnancies and save public dollars along the way. For these reasons, we urge your support.
Thank you very much. Next, sir.
Good afternoon. My name is Dr. Mitchell Crennan. I am currently Professor and Chief of Family Planning in the Department of Obstetrics and Gynecology at the University of California, Davis. Although I am a physician with the University of California, Davis Health System and have been a health professional practicing in this area of expertise for 24 years, the testimony and expert opinion that I'm providing represent my own personal and professional opinions and do not reflect an official position of either the University of California, Davis Health System or the University of California. Today I speak to you as a specialist in family planning and have published more than 250 studies and books in the field. As a specialist, I recognize this bill represents a leap forward in our ability as a society to support women and their families who want to control their fertility. Allowing women to have up to 12 months of their prescription contraceptive from a single visit to a pharmacist is vitally important for the health of the citizens of our state, while being cost-saving to the state, both in the private and public sector, including insurance companies and society as a whole. Unlike other prescription contraceptives, unlike other prescription medications, oral, patch, and vaginal ring contraceptives have a time-sensitive nature. If a man or woman misses a day or two of a blood pressure medication or a cholesterol-lowering medication, it is highly unlikely that any medical consequences will occur. However, for a woman using an oral patch or vaginal ring contraceptive, missing a few days can result in an unintended pregnancy. The time-sensitive nature of these medications is what makes this bill so important. You might ask, what's the big deal? Why can't a woman just go to the pharmacy every 1 or 3 months to get her prescriptions renewed? The reality is that we all have busy lives. We all may be late in picking up prescriptions or missing a few days here and there, but it's the time-sensitive nature of these medications that make us need to pay more attention and why this bill is vitally important. The state of California actually studied providing 12 months of oral contraceptives to women, so we have hard data from our own state, and all the other states that are looking at bills of this nature. Oregon looked to this study. So here we are in California where the study was done. The California study looked at providing 12 months of oral contraceptives to women through the Family PAC program and compared pregnancy rates in those who received a 1-year supply as compared to those who were limited to 1 to 3 packages at a time. And this occurred in 2006. The study included more than 84,000 women who received birth control pills, and for the women who were seen at clinics at which they could obtain a 1-year supply, about 1/3 selected 3 months or less, about 1/3 obtained a 12-month supply, and the last third received between 3 and 12 months. So women who could receive up to 12 months could judge on their own what was appropriate for them, and didn't all go out and get 12 months and stock up their cabinets. The pregnancy rate was reduced by 30% among women who chose to get a 12-month supply as compared to a 1 or 3 month supply. And the abortion rate was reduced by nearly 1/2. Assembly members, these types of findings in medical research are just amazing. For the time-sensitive treatment that we're talking about, providing a 12-month supply changes lives. It decreases unintended pregnancy rates and abortions substantially. And lastly, a word about safety. Providing a 12-month supply of a very safe medication will not put any patients at increased risk. The CDC does not recommend any follow-up for women who receive a prescription for an oral patch or vaginal ring contraceptive. The CDC selective practice recommendation states that no routine follow-up visit is required other than routine visits she would get otherwise for her health care. Accordingly, a woman who receives a 12-month supply of contraception is not at greater risk than a woman who receives her 1 or 3 month supply and then gets to return for multiple refills. In closing, hormonal contraception is safe, but the barriers that we put in place for women who are attempting to avoid unintended pregnancy are completely unnecessary. Studies in California have proven that we are harming women and families and increasing health care costs for the state by limiting supply of these contraceptives. I know that California women will benefit from this bill, and for these reasons, I ask for your aye vote.
Great, thank you very much. While noting that we actually have a quorum, I'm going to ask the Secretary, before we ask for additional support, ask the Secretary to take the roll, please.
Wood?
Aye. Here.
Wood here. Mainstein? Bonilla? Bonilla here. Burke? Campos?
Okay.
Campos here. Chu? Chu here. Gomez? Hernandez? Hernandez here. Lackey? Nazarian? Nazarian here. Olson? Olson here. Patterson? Patterson here. Ridley Thomas? Ridley Thomas here. Rodriguez? Rodriguez here. Santiago? Santiago here. Steinnorth? Thurmond? Waldron? Waldron here.
Okay, we have a quorum. So at this point, I'd like to ask for additional support, name and organization only, please.
Good afternoon, Christina Romero, co-sponsor of the bill with Planned Parenthood Affiliates of California. We strongly support.
Thank you.
Hi, Rebecca Griffin with NARAL Pro-Choice California, also a co-sponsor of the bill, here in support.
Thank you.
Shannon Smith Crowley with the American Congress of Obstetricians and Gynecologists for California, in support.
Thank you.
Teresa Stark on behalf of Kaiser Permanente, in support.
Thank you.
Kathy Mossberg on behalf of the Local Health Plans of California, in support.
Thank you.
Tam Ma with Health Access, in support.
Thank you.
Megan Brightwell on behalf of the California Primary Care Association, in support.
Great.
Kimberly Chen with the California Pan-Ethnic Health Network, in support.
Okay.
Justin Garrett with March of Dimes, in support.
Thank you.
Maya Ingram with the ACLU of California, in support.
Thank you.
Rosanna Carvacho on behalf of the Alameda County Board of Supervisors, also in support.
Thank you.
Helene Meshar on behalf of the City of West Hollywood, also in support.
Great, thank you.
Chris Rosa on behalf of Bayer, in support.
Great, thank you very much. Anyone in opposition? Please come forward.
Stephanie Watkins on behalf of the Association of California Life and Health Insurance Companies. First of all, I'd like to thank the author and sponsor. We've had an open dialogue and an iterative process. Unfortunately, we're still here today with an opposed unless amended position. The two amendments that we are seeking are, one, a clarification that on an initial prescription, a plan can require an individual to be stabilized on that drug prior to filling it for the 12-month script. Part of that is because our plans are reporting anywhere between 11 and 34% of women change agents at least once during a 12-month period. So we'd like to see that added into the bill to give additional discretion for a stabilization requirement. The other thing has to do with a delayed effective date. Given the timing of open enrollment and the products being rolled out, we would respectfully request a year delay so that our plans have the opportunity to update their vendor agreements during the normal process. They would also need to update their EOCs and the benefit package design so that those could go out and be available to the public so they would know what benefits are available to them. So for those reasons, we would respectfully request those two amendments. Thank you.
Okay, thank you.
Good afternoon. I'm Jennifer Alley with the California Association of Health Plans, and our members currently, provide contraceptives to women. The ACA, there's no copay for those, and we want our enrollees to receive the medication that they need in assisting them in planning their reproductive health. However, we do support the amendments that were discussed by my colleague. We think that they're critical in ensuring that there isn't that the benefit is rolled out as efficiently and as economically as it could be. And we, too, have had an open dialogue with the sponsors, and we appreciate that. It's just unfortunate that we haven't been able to reach an agreement at this time. Thank you.
Okay, thank you. Others in opposition, just your name and position, organization.
John Winger on behalf of America's Health Insurance Plans. We would echo the comments of Cap and Ackley.
Great, thank you. Anyone else? Okay, seeing no one, we'll bring it back to the committee. Questions, comments? Ms. Olson?
Thank you, Mr. Chair. Just a couple of questions, and I apologized I was late. I was running in from another committee. But now that California law says we don't need a prescription in order to pick up birth control, would that still apply to the 12-month supply, or would a woman have to get a prescription?
They can go through their doctor or their pharmacist, but have the jurisdiction. And they have a whole lengthy list of protocols, and I can let our technical experts help on this if I don't get this right. And they have complete discretion to limit to 30 days or 90 days. It just says up to 12 months at their professional discretion. It's the pharmacist, it's the doctor, the dispenser, the doctor. And is there did I get that right legally?
Yes, you did. Yes, the bill, we did make sure to amend the provisions in the Business and Professions Code to ensure that pharmacists dispensing or furnishing, rather, under protocols could furnish up to 12 months. But as the Senator mentioned, it's entirely discretionary.
Okay, great. And then, again, you may have addressed this in one of your opening comments, but any storage concerns? One of the letters brought up, are there questions as to, it relates to storing pills for 12 months as opposed to 1 to 3? In terms of the viability of the product?
The viability of the product, and that's probably the one in the refrigerator or not. I'm going to let the doctor answer this because he had such a great response back in the Senate.
So, well, for pills, there is an expiration date, and I think the pharmacist has really good enough training to look at the expiration date and tell if it would expire in a year, which is really good. And the other products, the patch is also a room temperature product, would have the same issue. The currently available vaginal ring, if it sits out for more than 3 months, would require refrigeration. And at least all the women I've met know how much room they have in their refrigerator when they go to the store to buy like milk or chicken, and usually don't buy more than they have room for. And given that the pack, a 12-month supply, would fit in a space about this big, I'm not too worried about women being able to store the ring in the refrigerator. And also in about a year and a half, we expect a room temperature ring to actually be on the market. And I would hate to have to waste the Senate and Assembly's time because there's now a room temperature ring as opposed to a refrigerated ring. And keep in mind that women who feel they don't have room in their refrigerator can choose not to take 12-month supply. Yes. They can say, I only want 3 months. And also, we're dealing with, we have studies to look at this, right, as opposed to just theory. So the studies show that only about a third of women, when given the option of taking up to a year, choose that option. So I think that we trust women with lots of decisions, including what method they want to use, and I think women can decide how much room they have to store.
Great. And then to the opposition, just a little more clarification on the First Amendment desired. You indicated that between, I think, 11 and 34% of women decide to try a different form of contraception. And I think that's probably accurate. So what is this stabilization requirement that you feel would help address that?
So the language would, and we worked on it in other bills, would allow the plan to require on the initial script a fill of 90 days, and then you could fill it for the remaining portion. So for any initial prescription, you would get a 3-month supply initially. Once you're stabilized on that drug, going forward, you would receive the remainder for that year and then any subsequent 12-month supply. So what we're really looking for is just on any initial script that you be stabilized on that drug prior to filling the entire 12-month script.
Okay, thank you. I'm generally supportive of the bill. I think this helps women, and I think it makes sense. I also think that desired amendment is very reasonable. I think it is fairly common for women, especially who are first starting contraception, to maybe desire a change for one reason or another, whether it's weight gain or any of a number of reasons. So I think the amendment makes sense. I would encourage the author to consider taking that as she moves forward, but I'll be supportive regardless, because I think, generally speaking, this bill moves in the right direction for women.
And I don't know if it's appropriate, but to respond whatever you'd like me to do.
How about in your close, unless if that's okay?
That's fine.
Super, thank you.
Yep.
Ms. Bonilla.
It's just a comment. It's about time. Thank you so much for bringing this bill forward.
It is about time. It's busy.
It's all about time. Mr. Patterson?
Just a clarification with respect to the request for the amendments. Are you willing and interested in taking those amendments as we move forward?
We always have had, and I think they've indicated, an open door policy. We're taking technical amendments in B&P as it moves forward. Those have been on the discussion. I personally feel that the doctor has that full discretion, and if I was a doctor and this was a first-time person getting oral contraceptives, I would probably limit them to 90 days so they come back and make sure it's right for their particular situation, medical stability and things like that. So that discretion is, I think, indeed built in. It's interesting to me to note, though, I'm not a doctor. I don't have any medical background. I'm a former middle school teacher. But every single medical professional, physicians assistants, California Medical Association, obstetricians, gynecologists, they all say this 12 months makes sense. The experts, say it makes sense. So it's sort of a balancing act, if you will. Do you sort of lean on the discretion with the flexibility inside the medical field? Or is this some other thing? So the discussion will continue, because we always continue to look at bills to see if that is the best appropriate way to go. I do know that Oregon implemented this identical bill over a year ago. No problems, no concerns. Discretion always with the doctor, absolutely. An arbitrary limit or number on how many days someone should have, depending upon medical stability, which is yet to be defined. Perhaps not. So I can't guarantee you that'll be taken. But if they can reframe the discussion, our door is always open, along with the sponsors. We have, I think they would all agree, and I know my staff does a great job in listening to all perspectives to make sure we get this right.
Thank you. I appreciate the willingness to consider and take those amendments along with Member Olson. I would like to encourage that to happen. Unfortunately, we are right now. We can only vote on what's in front of us.
Right.
And so I would encourage you to continue to work with the opposition. It seems to me a reasonable amendment. And if, well, sir, then if the answer is no, then then right. I have to vote a different way. Okay. I really believe that you ought to try to accommodate a reasonable. And if what I don't understand is if it is implied in the bill, and what they're trying to do is amend so that what's implied in the bill is unambiguous, then I don't understand the difficulty in not taking the amendment. But anyway,
it's nuanced.
We don't need to belabor
it. It's left to the discretion. The bill only says up to 12 months. Right now, the limit, it's an insurance mandate that's probably objectionable here, not the health side of this. So we can clarify that. But all this bill does, instead of saying limiting to 90 days, 30 to 90 days, at the discretion of the doctor, it's up to 12 months. All this is a discussion of the timing, and whether it's family pack or the new rules under Medi-Cal managed care plans, everything is up to 12 months. All the other states are going to up to 12 months at the discretion of the doctor, who's probably the best person to make that decision, along with conversations with his patient.
I was asking about the amendment and whether or not there was a possibility as it moves forward. I guess the answer to my question is no.
At this time.
Yeah.
Okay. Other comments or questions from other members? I have a couple myself. So, actually, first one to Dr. Crennan. There are side effects to certain different kinds of medications, whether it's contraceptives or lots of medications. Is there a fundamental objection to the initial? I'm curious because I watched you nod there. What is the fundamental objection to asking that initial, not subsequent, prescription be limited to 90 days, so that if there are side effects, that we don't end up with a situation where someone has been prescribed something for a year that they can't use beyond 2 months? And so I'd love to hear your answer on that.
Sure. Thank you for asking. Well, the premise of the attempt to restrict has 2 points. One is that it's going against a study, and this is theory. So keep in mind what they're asking is theory, and what you're requesting by limiting is theory. You have a hard scientific study that proves that when you allow women to take up to 12 months, it doesn't mean that they go in for their first prescription and they take 12 months, but you allow them to make that decision. You have hard evidence that shows that when you put that in place, unintended pregnancy rates go down, abortion rates go down, costs go down. So theory then blows out the window when you have hard scientific evidence.
Appreciate that.
Right.
That's not the question.
That's the second part then, is the side effect part runs into that. So when a person gets a prescription from their pharmacist or their physician or other healthcare provider, that's part of the information that's gone over with the patient. And then it's up to the patient and the provider to decide, do you want to start, if you've used this before, do you want to get a larger supply or less of a supply? Most women, when starting a new medication, are not going to, and that's what the studies show, aren't going to walk out with a 12-month supply. They're going to pick a few months to see if they tolerate it. Most physicians recommend start with a month or 2 and see how you tolerate it. So the recommendation typically is to do that. Mandating it by insurance goes against the study, which says that if a woman for example, then if a woman changes insurance plans but's been on the same contraceptive before, then the implication of this amendment would then limit her under the new insurance plan to going back to just 3 months supply, when she already knows that she does well on this product. So giving the woman the option, having her understand what the side effects are, discussing those with her healthcare provider or the pharmacist, then allows her to make that decision. And when given that information and it's studied, unintended pregnancy rates go down, abortion rates go down, and incredible cost savings.
Great. Okay, thank you. Question back, so another question would be back to the opposition. You asked about a delayed implementation. So my understanding of the way things work, the department could delay implementation. It's not required that this be in statute. Is that correct? A waiver. There could be a waiver that would allow for a delayed implementation of this. So it wouldn't necessarily be necessary to put it in statute. The department could request a waiver.
I'm not sure. That's not been my personal experience with the departments. Things have been delayed through a regulatory process. If, say, something says there's a July 1st date and then there's a regulatory process. That being said, there could be a waiver. I think our general request for many of these bills, especially given the timing, cover California, you have open enrollment. We already have policy forms that are filed way earlier in May and June that are approved by the departments. What we would like to see is additional time granted in order to amend EOCs, update our pharmacy and our vendor agreement so that it shows that this would be the new policy. And those would all be done through the normal course of action, so we wouldn't have to send out additional notice provisions to folks. So that's usually why we ask for the delayed implementation. It's just so that everybody's on the same process and the same policy and people know what the rules are prior to us then issuing them.
Okay. All right. Well, thank you. Appreciate that. Any other questions or comments? So we have, I'm going to give the author an opportunity to close first. We have a motion in a second. So
yes, and thank them both for the motion and the second. Just 2 comments, if I may. We've had for over 20 years a program called Family Pack in place for low-income women that have allowed 12 months dispensing for over 20 years. Not been a noticeable problem. We've recently, in February, the Medi-Cal managed care plans are required to provide, all the insurance companies that have Medi-Cal managed care plans are required to provide this same thing up to 12 months. This just builds on what is argumentatively a large percentage of our population already. This is not a new insurance mandate. This is just a time situation of whether it's 30 days, 90 days, allowing up to 12 months at the discretion of the doctor and his patient. Ask for your aye vote.
Great. Thank you very much. So we have a motion and a second. The motion is due pass to business and professions. Madam Secretary, please take the roll.
Wood?
Aye.
Wood, aye. Mainshine? Mainshine, aye. Bonilla? Bonilla, aye. Burke? Campos? Campos, aye. Chu? Chu, aye. Gomez? Hernandez? Lackey? Nazarian? Nazarian, aye. Olson? Olson, aye. Patterson? Patterson not voting. Ridley Thomas? Ridley Thomas, aye. Rodriguez? Rodriguez, aye. Santiago? Steinnorth? Thurmond? Thurmond, aye. Waldron? Waldron, aye.
That motion that bill passes 11-0. We'll leave it open for additional members to add on. Thank you, Senator.
Thank you very much. Appreciate it.
We have a motion and a second on the consent calendar. Madam Secretary, please call the vote.
Wood?
Aye.
Wood, aye. Mainshine? Aye. Mainshine, aye. Bonilla? Bonilla, aye. Burke? Burke, aye. Campos? Campos, aye. Chu? Chu, aye. Gomez? Hernandez? Lackey? Nazarian? Nazarian, aye. Olson? Olson, aye. Patterson? Patterson, aye. Ridley Thomas? Ridley Thomas, aye. Rodriguez? Rodriguez, aye. Santiago? Steinnorth? Thurmond? Thurmond, aye. Waldron? Waldron, aye.
So consent calendar passes 13-0. Happy to entertain a motion on item number 1, SB 123. So we have a flurry of motions and seconds. Madam Secretary, please call the roll. We'll call Mr. Ridley Thomas, and we'll give to Ms. Campos over there. So for the second, the motion is due pass to education. Please call the roll.
Wood?
Aye.
Wood, aye. Mainshine? Mainshine not voting. Bonilla? Bonilla, aye. Burke? Burke, aye. Campos? Campos, aye. Chu? Chu, aye. Gomez? Hernandez? Lackey? Nazarian? Nazarian, aye. Olson? Olson, aye. Patterson?
Oops. Rewind.
Olson not voting. Patterson? Patterson not voting. Ridley Thomas? Ridley Thomas, aye. Rodriguez? Rodriguez, aye. Santiago? Steinnorth? Thurmond? Thurmond, aye. Waldron? Waldron not voting. Lackey?
Not voting.
Lackey not voting.
So that sits at 9-0. We'll leave the roll open for additional vote later on. Item number 3 has been moved by Mr. Ridley Thomas and seconded by Ms. Olson. The motion is due pass as amended to appropriations. Madam Secretary, please call the roll.
Wood?
Aye.
Wood, aye. Mainshine?
Aye.
Mainshine, aye. Bonilla? Bonilla, aye. Burke? Burke, aye. Campos? Campos, aye. Chu? Chu, aye. Gomez? Hernandez? Lackey?
Aye.
Lackey, aye. Nazarian?
Aye.
Nazarian, aye. Olson? Olson, aye. Patterson?
Aye.
Patterson, aye. Ridley Thomas?
Aye.
Ridley Thomas, aye. Rodriguez?
Aye.
Rodriguez, aye. Santiago? Steinnorth? Thurmond? Thurmond, aye. Waldron? Waldron, aye.
That item passes 14-0. We'll leave the roll open for additional members to add on. We'd ask members to come down as quickly as they can. We do have an initiative hearing immediately following this health committee hearing, so we'd ask members to please come down and vote. We can. Did you just? So we're going to open the roll on remove the call on the consent calendar for Mr. Lackey. Okay. Oh, sorry. Oh, sorry. Would you like to add on to 1, 2, 3?
Yes.
Okay.
Lackey?
Aye.
Lackey, aye. It's 10-0.
That item passes now 10-0, so we're just looking for add-ons at this point. So all the items have passed the committee. We're just going to wait. We're going to wait about 5 minutes.
The consent calendar? Okay. Lackey, aye on the consent calendar?
Yes.
And SB 999?
Aye.
Lackey, aye.
Well, you can leave it up for 5 minutes. Excuse me, Jim. 5 minutes. We got to call the Will Steinhardt, but he's presenting in the Senate Judiciary as well. So Steinhardt here. He said, Scott, 5 minutes. All right, so that was the Senate Sergeant, Room 12. So he's got Mr. Steinberg. He's presenting 3 bills, and he's on his number 2 of 3. 42 is Scott speaking. 3. Hi. He said 5 minutes.
Okay, SB 123, Hernandez. Senator.
Aye.
Hernandez, aye. Consent calendar?
Aye.
Hernandez, aye. SB 969?
Aye.
Hernandez, aye. And SB 999?
Aye.
Hernandez, aye.
Is that it?
So just so you know, we're not officially adjourned from the Health Committee hearing, which we will do in about 2 minutes, and then we will take up the tobacco tax initiative hearing. So it gives about 2 minutes. Okay. Okay, I'm going to go ahead and adjourn the Health Committee hearing, and in just a moment we're going to wait for Dr. Hernandez to come back in, and then we'll go ahead and get started here. So we're going to